I'm Laurie Sehn from BC Cancer in Vancouver, Canada, and today I'm going to be talking about some recent updates in follicular lymphoma and mantle cell lymphoma. So for follicular lymphoma, we know that frontline therapy still relies on chemoimmunotherapy. The Gallium study was a seminal trial that compared obinutuzumab to rituximab as the initial CD20 monoclonal antibody combined with an investigator choice of chemotherapy backbone. And what we've seen recently is the long-term Gallium study follow-up that was reported by Dr. Townsend at EHA this year. This included follow-up of up to 8 years, so really a prolonged look at the result of this trial. So this trial's primary endpoint was progression-free survival. And at the time of reporting, we found that there was an improvement with the use of obinutuzumab over rituximab in terms of progression-free survival, and that absolute value was approximately 7%. Well, now with 8 years of follow-up, it's reassuring for this indolent lymphoma that difference has been sustained, but it's pretty much parallel to where it was. So I'd say that the conclusion is actually quite similar, that we see this modest improvement in progression-free survival with the obinutuzumab rather than the rituximab up front, but still with the longer follow-up, no difference in overall survival. What was intriguing is they also looked at the safety over time with the two monoclonal antibodies. So this slide divides the safety follow-up for the induction phase, followed by the maintenance, and now during the post-maintenance observation phase. Although at the time of initial reporting, the progression-free survival was significant and that led to the approval of obinutuzumab, I have to say that the uptake has probably been partial across the community of people that treat lymphoma. So I myself continue to use rituximab, and part of my reluctance was perhaps the modest benefit, but also a slight increment in toxicity with the use of obinutuzumab. And early on, you can see that really related to the infusion-related reactions, which was higher, but also a higher level of neutropenia and infection, and particularly in the patients receiving bendamustine with the obinutuzumab, there was actually concern for fatal infections. Over time, with the maintenance phase, that seemed to also persist with a higher risk of infection in the patients who were receiving the obinutuzumab. Now in the observation phase, with all patients off treatment, I think it's still intriguing to see that there's a slight signal of increased sustained neutropenia in the obinutuzumab arm, as well as a slightly higher rate of infection in the patients in observation. So I think it's interesting to see this long-term follow-up. The efficacy endpoint hasn't been altered, but I think it's noteworthy that the slight excess in toxicity has been sustained over time and would definitely need to be considered by clinicians using obinutuzumab preferentially.
So, the hazard rate for PFS is comparable 0.77. I mean, I've seen action taken on those kind of hazard rates in other situations. So, but maybe it's just more for historic interest. But one of the issues has always been the amount of drug and whether that's the issue as opposed to the drug itself. I don't know if there's any way to resolve that. Any thoughts about that?
So the schedule of administration is very similar. The dose of obinutuzumab, though, is optimized for its unique pharmacokinetic profile. So although it is probably, milligram for milligram, a higher dose than rituximab, the optimal dose was based on really its own unique pharmacokinetic profile. So I'm not so sure it's a dose effect. I think it is an agent effect. I mean, it is a different monoclonal antibody and clearly, has more efficacy in follicular lymphoma. And this is the one indication where, one of the indications where it really has shown to be more effective. I think the issue is that this is a non-curable lymphoma at this point in time. And patients will go on to get successive therapies most of the time. And although progression-free survival is the primary endpoint that we look at, because overall survival is so prolonged that it's impossible to run trials that really use that as an endpoint, everything gets balanced in terms of progression-free survival against toxicity. And I think there is definitely a signal of excess toxicity with obinutuzumab, or increased toxicity, I should say. So it becomes a risk-benefit balance. And while many clinicians have universally switched over to it, I think that rituximab is still fair game in this setting. It's also, of course, slightly more expensive than rituximab in some environments, particularly now with rituximab being available with biosimilars. So there's also a cost issue in some settings to consider, or access issue. But for myself, I would probably individualize it on a patient-by-patient basis. We know that patients with higher risk disease, so higher FLIPI scores, maybe we want to be a little bit more aggressive in those patients, and the use of obinutuzumab is probably more justifiable. But if I had kind of a lower risk patient, I'd say that I would be more comfortable using the rituximab because of the lower toxicity profile.
All right, great. Please continue.
So although chemoimmunotherapy is still embedded as a frontline setting for follicular lymphoma, I think we're all enthusiastic about moving away from chemotherapy. Everybody remembers the Relevance trial, which was the large upfront trial that was aimed at bringing in a non-chemotherapy approach into the frontline setting, namely rituximab and lenalidomide, what we refer to as R squared. So in the Relevance trial, R squared was pitted head-to-head against rituximab and chemotherapy, again, investigator choice chemotherapy, in the frontline setting for follicular lymphoma. This trial was designed as a superiority trial. It was aimed to show that R squared was actually better. And unfortunately, because it didn't meet that endpoint, so it was essentially declared a negative trial, meaning that there was no benefit to R squared over R chemotherapy. R squared didn't get an indication in this setting, but was quite noteworthy with the initial publication of this, which had a median follow-up of about 3 years. It was noteworthy that the curves were pretty much superimposable, and had it been designed and statistically powered for non-inferiority, we would have said that the approaches were non-inferior. But ultimately, the outcomes looked identical. So this year we saw publication of the longer-term follow-up of Relevance. So now we've got 6-year data, and I think it's really quite compelling, as you can see on the right side of the slide, that the progression-free survival and overall survival with longer follow-up has really shown to be identical. I think this also provided reassurance that despite the use of lenalidomide and rituximab up front, there was no hint of excess toxicity in that group, no hint of an increase in secondary malignancies of relevance. And also, when patients went on to need second-line treatment, and many of them went on to get chemoimmunotherapy, there seemed to be no compromise in the outcome following second-line therapy. So I think this has been a reassuring long-term follow-up in my mind. So if I had a patient where I wanted to avoid chemoimmunotherapy, I would feel comfortable with R squared up front being a quite comparable alternative to our chemotherapy, and also knowing with this longer term follow-up that I'm hopefully not causing the patient any untoward harm in the long term, and they still have, the same doors open to them and outcomes, hopefully, when they go on to get secondary therapy. So along the lines of moving away from chemotherapy for follicular lymphoma, I think the real game changer is that we are now seeing the evolution to bispecific antibodies. So we've been talking about bispecific antibodies for a long time in lymphoma and follicular lymphoma. And now we just had the recent FDA approval of mosunetuzumab for patients with relapsed refractory follicular lymphoma. So we can stop talking about the bispecific antibodies coming and say that they're actually here now and should be available for clinical use, very shortly, if not already. So what we saw presented at ASH was the longer-term follow-up of the pivotal data of mosunetuzumab in patients with relapsed refractory follicular lymphoma. This had been presented last year at ASH and was initially published by Dr. Buddy in JCO, but now we saw even longer-term follow-up presented by Dr. Bartlett at ASH. So this is a trial that looked at mosunetuzumab as monotherapy for follicular lymphoma in patients who had received at least 2 prior lines of therapy. This is a finite therapy. Mosunetuzumab in this trial was given intravenously. For all of the bispecific antibodies in cycle 1 of therapy, there's a requirement for step-up dosing. So it gets given in baby doses prior to the full dose being administered as a way of trying to reduce the risk of cytokine release syndrome. So here we have it administered 3 times in the first cycle, and then subsequently it gets given once every 3 weeks. It's intended to be given for 8 cycles total, and then patients get restaged. Patients in a complete remission would stop after 8 cycles only, and those who are not in complete remission would go on to receive up to 17 cycles of treatment. So again, finite intended treatment. In this pivotal experience where 90 patients were treated, what was so remarkable is that despite the fact that this was a high-risk cohort of multiply treated patients, median number of prior therapies was actually 3 prior therapies. The overall response rate was 78%, and the complete response rate was 60%. So here was a group of patients that was largely refractory to CD20 monoclonal antibodies, largely refractory to their last therapy, and we saw remarkable response rates noted. But what, of course, we're more interested in is what is the durability of benefit. So with this analysis that had up to approximately 18 months to 2 years of follow-up, what we can see here is that for the patients who responded and actually achieved a complete response, the median duration of that complete response has not yet been achieved. So you can see on the left side of this curve, we see the duration of complete response. And on the blue curve, you can see that the patients receiving mosunetuzumab up to the 2-year mark and beyond, the majority of those patients are still sustaining a response. The red curve is how they did with their last prior therapy. So one of the paradigms that we've seen with follicular lymphoma is that patients that go on to get successive lines of therapy tend to do worse with their next line of therapy. So response rates are lower, progression-free survival, duration of response is lower. This is a shift of that expectation where you see the blue curve of the mosunetuzumab doing much better than what patients achieved with their last prior line of therapy. And on the right side, you can see the progression-free survival, where we now have the median progression-free survival reported as 24 months, which again is quite impressive for this multiply treated patient population. And you can see here again how there's that shift in our expectations, where the red curve on the right is how the patients did with their last line of therapy and progression-free survival, and the blue curve is how they're currently doing with mosunetuzumab. But what about the toxicity? So this is an agent that I would say is very well tolerated. The main toxicities are seen in the first cycle, where cytokine release syndrome is a potential side effect. But for the most part, it was low-grade in nature and mainly treated with supportive management. So relatively few patients in this trial needed tocilizumab administered, and in all cases, the cytokine release syndrome was largely reversible and transient. Aside from cytokine release syndrome, we see some element of neutropenia, but the infection rate was quite low, and in terms of other side effects, most of them were quite low grade. So I think it's quite exciting that we're really seeing now the emergence in the clinical setting of these agents for the first time, that our expectation is that this will become a highly utilized treatment for patients with follicular lymphoma. And I think that ultimately we're going to see really improved outcomes in this patient population as a consequence to this new therapy becoming available. But mosunetuzumab is not the only agent being tested. Of course, there are several anti-CD20, CD3 bispecifics in development. We saw another one just recently presented at ASH. This was the pivotal data in the follicular lymphoma cohort for odronextamab, which is also an agent that's fairly long in development in numerous non-Hodgkin lymphomas. This agent's given a little bit differently. So again, what they presented was data in the pivotal follicular lymphoma cohort. This drug is given intravenously every 21 days as well, but is given more frequently in the initial cycle. So beyond the step-up dosing in cycle 1, it gets given weekly for the first 4 cycles, and then gets given every second week up to progression. So it's not finite, but given technically indefinitely as long as patients are tolerating it. But again, here what we saw is in this highly pretreated patient population, very high overall response rates in the range of over 80%, and a high complete response rate here of 75%. And here you can see again the median duration of response in this experience was just over 20 months, and the median duration of complete response was approximately 26 months. So very durable benefit for many of these patients. I think now that we're seeing emergence of monotherapy of bispecific antibodies, what is also a very active area of investigation is how are we going to combine these with other treatments to make other treatments better or to find more effective combinations, and how might we move them forward into earlier lines of development. So there are many clinical trials right now looking at combining bispecific antibodies with standard therapy. A favorite to combine it with is R-squared, so rituximab and lenalidomide, to make a I would say like a triplet immunotherapy, since we would think that hopefully the bispecifics and the use of lenalidomide with the bispecifics might actually augment the effectiveness of both. So it's sort of a logical combination to include together. And it actually saw 2 presentations of epcoritamab, another bispecific antibody in development, combined with lenalidomide and rituximab. In this presentation, they looked at a group of patients in the relapsed refractory setting for follicular lymphoma. Here we've got, of course, the R-squared given in a finite way with up to 12 cycles, so 1 year of therapy of the lenalidomide, and then the epcoritamab was dosed up to 2 years of treatment. This is still fairly early data, but very encouraging to see that there are very high overall response rates here at 96% and an 83.5% complete response rate, and the median duration very impressive here, but still early data with median follow-up only 6 months. But demonstrating feasibility of combining this as an approach, and also early suggestion of high benefit. These same authors actually explored the use of the same bispecific, so epcoritamab with lenalidomide or rituximab, here in untreated follicular lymphoma. So similar to Relevance, which demonstrated R-squared as effective frontline, here adding in the bispecific frontline. And again, very intriguing overall response rate of 94%, complete response rate of 86%, and very impressive duration of response, although still too early to say. So we're starting to see now combination approaches with bispecifics emerging, again, demonstrating safety and strong signals of benefit. What about other novel therapies in follicular lymphoma? So tazemetostat, which is an EZH2 inhibitor, has already been approved and is available for treatment of follicular lymphoma in the relapsed refractory setting. What we know about tazemetostat is that it works best, or at least was shown in the pivotal data, to have better efficacy in patients that had what we call mutant patients that had mutations in EZH2. That's only about 15% of the follicular lymphoma population. So the majority of our follicular lymphoma patients will have wild type EZH2. The pivotal trial showed benefit in both subgroups, but higher response rates and maybe slightly progression-free survival in the mutant subtype. This analysis was a relook at that trial and that data, but performing this time a matched analysis. Because we look back at that pivotal trial, what we saw is that the patients that were included in the mutant arm of the trial actually had more prior treatments, sort of had higher risk disease. So they weren't really comparable cohorts in terms of clinical characteristics. But this was an intriguing attempt to match the patients according to clinical characteristics to try and pick out apples and apples, so the same kind of patient. And you can see here that on this propensity score matched analysis of that initial data, the progression-free survival is actually quite comparable whether or not you had mutant or wild type follicular lymphoma. So I think this tells us that this agent has potential efficacy in both, and maybe better efficacy in wild type than we were led to believe from that initial trial when we match patients sort of with similar characteristics. So this agent is also moving forward in development in the combination setting. So it's being combined in several trials with lenalidomide and rituximab, for example. At ASH, we saw the safety data emerging from a planned and ongoing trial that had a built-in safety phase 1B study with plan to push this forward to a phase 3 study. So the intention is to compare R squared versus tazemetostat and R squared, but the initial phase 1B run-in was performed to look at safety and also an initial signal of efficacy. So what we saw here in the patients included in the safety analysis, which was 40 patients, the majority of them had wild type, as we might expect by the distribution of the patient population. But what we saw was that it was actually very safe. There were no concerning signals of augmented toxicity associated with the R squared. But you can see here that the overall response rate was very high, 97% in the wild type and 100% in the mutant subgroup population. Again, you can see maybe a little bit of difference here in the complete response rate, which was 70% in the mutant type patients and 45% in the wild type. But again, numbers are small in the safety cohort. But looking at the right side of this, you can see that the progression-free survival was similar in both cohorts. So I think this provided the signal of benefit that they needed to move this forward and the signal of safety. So, I look forward to the initial and future results of the phase 3 trial that will be ongoing for some time. The other novel therapy that's become available for follicular lymphoma, of course, is CAR T-cell therapy. So based on the ZUMA-5 data, axicabtagene ciloleucel was approved for follicular lymphoma after 2 prior lines of therapy. Now, this was recently published, and this trial looked at a group of patients with follicular lymphoma as well as marginal zone lymphoma. We can see here that the response rates were high in both cohorts, but there was a signal of maybe more activity in the follicular lymphoma cohort, where the overall response rate was very high, as you can see there, at 94%, with the majority of those patients achieving a complete response, slightly lower overall response rate of 83% in the marginal zone cohort of patients. But with the progression-free survival, we can see here quite intriguing benefit in the follicular lymphoma patients. The blue line shows sustained benefit for a high proportion of patients, now out with a median follow-up of about 18 months, but you can see there are patients out now beyond the 2-year mark with sustained progression-free benefit. Interestingly, that red curve with the marginal zone lymphoma does come down a bit more. It's still the smaller cohort of patients, so I think it's hard to make too much out of a small cohort. But again, I think we're seeing a signal that this may be more effective for follicular lymphoma than marginal zone lymphoma. But we also saw data published and updated at ASH looking at Tesogen, essentially or Tesocel in follicular lymphoma. So this was a comparable study here using Tesocel, and we're seeing very similar results with high level of efficacy seen in patients with follicular lymphoma. You can see that patients, particularly those achieving a complete response, are having quite durable benefits, with follow-up now in this trial being over 2 years. So the median follow-up was 29 months, and many patients having sustained benefit. I think the intriguing thing is, in terms of a chronic disease that we don't think, we have a curative approach for at this point in time, I'd say that the data on CAR T-cell therapy is still too early to say whether or not this is going to be a game changer in terms of something that may offer curative potential. So we still need much longer follow-up than we have right now. But this is the longest follow-up analysis we have of CAR T-cell therapy in follicular lymphoma. And you can see here with a median follow-up of 29 months, of those patients who achieved a response, so the CR and the PR patients, I don't know, you can argue that we might be starting to see a bit of a plateau, or at least certainly those patients achieving a CR, those that are progressing are doing so within the first 2 years, and beyond that, we're not seeing further progression. So certainly I'm, excited to see the longer term data of this, which I think is going to be what we require to really know whether or not we're going to be seeing any cures with CAR T-cell therapy in follicular lymphoma. Nonetheless, it is showing itself to be a very effective treatment. So I'm going to switch gears here and talk a little bit about mantle cell lymphoma. Mantle cell lymphoma, of course, is an aggressive B-cell lymphoma that is still a very big challenge to treat, because at this point in time, we don't really have a curative treatment option. On the positive side, this is a very active area of clinical research, and we're seeing novel therapies coming to fruition, but we're still challenged with how to best optimize the treatments that we do have to offer patients the best control of disease possible. So right now, most of us use chemoimmunotherapy up front, and for patients who are not transplant candidates, bendamustine and rituximab, I would say, is probably the preferred chemotherapy in many settings because it's so well tolerated and it's highly effective. We saw a publication of the Sehn data. So this was a long anticipated phase 3 trial that was comparing head-to-head the standard approach of bendamustine and rituximab for 6 cycles, followed by rituximab maintenance, with the same treatment plus the addition of ibrutinib in a 1-to-1 fashion in patients with previously untreated mantle cell lymphoma who are not planned for stem cell transplant. The primary endpoint of this trial was progression-free survival, and we can see here that the trial met its primary endpoint with a significant improvement in progression-free survival. So the median progression-free survival was actually improved by 2.3 years with the addition of the ibrutinib. So with the hazard ratio showing a 25% improvement. Unfortunately, there was no improvement at the point of follow-up in overall survival. And I think what was concerning is that despite the improvement in progression-free survival, we were seeing some excess toxicity in the ibrutinib plus BR arm. So we know that BTK inhibitors are associated with a unique set of toxicities, including the risk of cardiac toxicity, atrial fibrillation, hypertension, arthralgias, bleeding problems, neutropenia. And what we saw is that in patients receiving the ibrutinib on top of BR, these toxicities did occur, and there was an augmentation in toxicity overall. So ultimately, the improvement in progression-free survival that we saw with the BTK inhibitor here was offset in overall survival by more patients, unfortunately, dying from unrelated events in the ibrutinib arm. So fewer deaths due to progressive disease in those getting ibrutinib, but a higher number of deaths due to treatment emergent adverse events. So I'd say that, I think the verdict's still out. This is open for discussion, I'd say, with patients as to whether or not they should receive ibrutinib in the frontline setting, but there clearly is a trade-off here in toxicity associated with this drug. So I think that it hasn't fully permeated clinical practice, but it is I would say, a clinically significant improvement in progression-free survival and clinically meaningful improvement in progression-free survival. But given the increase in toxicity, I think it's still open for question as to whether or not you might get to the same place if you use this sequentially and come in with your BTK inhibitor as necessary in the second-line setting. Having said that, we know that BTK inhibitors are firmly grounded in the second-line setting for mantle cell lymphoma and have been a real game changer in that setting. So the ability to try and move these forward obviously is a high area of research and expectation. At ASH, we saw a very high-profile presentation that was actually the #1 abstract of the entire meeting and presented in the plenary session at ASH. And this was the Triangle study, which was performed by the German Mantle Cell Lymphoma, or the European Mantle Cell Lymphoma Consortium. And this was a 3-arm study. It is a little bit complicated, but is a 3-arm design that was initially intended to assess the efficacy and safety of moving ibrutinib into the upfront setting for transplant-eligible patients with mantle cell lymphoma. So the standard of care arm here is the arm where patients receive R-CHOP alternating with R-DHAP as part of induction, which is a standard accepted frontline induction, followed by autologous stem cell transplant, followed by observation. We know that many patients are now getting rituximab maintenance post-stem cell transplant, which is more recently demonstrated to improve overall survival. In terms of the course of this study, it was not built in, but was up to investigator discretion. And I'd say that the data probably evolved over the course of the study. So probably toward the end of the study, more patients had the rituximab added in. According to the presentation, about half of the patients received rituximab maintenance. But again, it wasn't built into this trial. It was investigator choice. So the standard arm included the alternating induction regimen followed by transplant, and the 2 experimental arms included one arm where ibrutinib was added into induction and maintenance, and the transplant was left in, and one arm where the ibrutinib was added into induction and maintenance, and the transplant was left out. So asking several questions in the context of this study. And the reason why it was the #1 abstract is because you can see here that the primary endpoint, which was failure-free survival, demonstrated a significant improvement for the ibrutinib included arms. So the arm that did the worst is that blue arm, which is the arm that did not have the ibrutinib added in, and the failure-free survival in the 2 ibrutinib arms, including the one that didn't include the transplant was actually superior. I won't go through all the details, just to let you know, it was a complicated statistical analysis. So they did 2-by-2 comparisons. But importantly, what they showed was, particularly for that group of patients that had the ibrutinib and the transplant, they were able to demonstrate a significant improvement in failure-free survival. And these are the overall survival curves. At this point in time, they are not significantly different, but I think what's most intriguing here is the gray arm of this is that group of patients that had the transplant left out. So the patients who had ibrutinib added in to induction and maintenance with no transplant, what we're seeing is they had a very high failure-free survival and no suggestion that their overall survival is being impacted by the omission of transplant. So I think, this is a complicated trial design. As I said, the statistical analysis was quite complex. Only half of the patients, as we were told in the presentation, had received rituximab maintenance. I personally would like to see more data come out and see the full publication, probably, for knowing how this should change my own practice. But some people are going to argue that this trial gives us some latitude to consider maybe dropping the transplant from the upfront setting for transplant eligible patients without inducing, sort of unnecessary harm. So I think this will be debated. We've only seen kind of the tip of the iceberg in terms of this data, but I think it's very intriguing that we may be seeing a shift in standard of care here. And certainly for my own patients, those patients who I'd say were kind of marginal transplant eligible patients, I certainly would have no qualms about omitting the transplant from their care and considering, if I had access to it, moving ibrutinib forward. So again, BTK inhibitors, very effective agents for mantle cell lymphoma, typically used second line and beyond currently, but many trials exploring their use up front. Here is a trial that was also presented at ASH looking at the combination of acalabrutinib, the BTK inhibitor, combined with R-squared. So we've seen data of R-squared published in mantle cell lymphoma, largely for patients who are not eligible for transplantation. And in the upfront setting, R-squared actually is quite effective for mantle cell lymphoma. And we saw data that showed sustained benefit in a population of patients. So this was an attempt to make a chemo-free upfront regimen of BTK inhibitor plus R-squared for mantle cell lymphoma. I like this trial also because it was an MRD adapted trial. So they measured MRD in real time. And for patients who achieved MRD negativity after the 1-year treatment of R-squared, they basically stopped all treatment and were observed, except for some continuation of maintenance rituximab. And the other arm was able to continue with the ongoing treatment. So this is not a large cohort of patients. It's only 24 patients. It is proof of concept at this point. But what we saw here was a very high overall response rate of 100% in this small cohort, complete response rate of 83%. And you can see on the right that many of these patients, the ones with the light blue arrows, did achieve MRD negativity, and many of them actually stopped treatment at the 12-month mark and were simply observed with what we can see here, quite sustained benefit. So again, very early data, small patient numbers, but what we see here is that the 2-year progression-free survival was over 85%. So, and intriguing combination with high response rates and demonstration of potential durable benefit, but particularly in this MRD adapted approach, some patients are receiving more finite therapy. The other novel agent that, many of us are interested in mantle cell lymphoma, not yet officially approved or indicated in this setting, is venetoclax. Venetoclax has single agent activity, but by itself has unfortunately not very durable benefit for mantle cell lymphoma. So ongoing clinical trials are exploring combinations with venetoclax to see how we might add this effective drug into other combinations and have an effective multi-agent combination. This data that we saw presented at ASH was a combination of venetoclax and rituximab with the BTK inhibitor acalabrutinib in a group of patients with untreated mantle cell lymphoma. Again, here an attempt to develop a chemo-free combination in the untreated setting. This also is very early data and a small cohort, but what we did see is that it was a highly effective regimen with a high overall response rate demonstrated. One concerning thing with the data that was presented against a small cohort is that in the small group of patients, they did have an unusually high rate of patients who died from COVID-related deaths. So actually 5 patients in this small cohort actually died related to COVID infection. Now, is this somehow a consequence of the combination? Well, we know that patients with lymphoma are at a higher risk of COVID-related complications and death. We know that patients on active treatment with B-cell depleting agents have a higher risk of COVID-related complications. Is there something concerning about this triple combination? Is it just an unfortunate circumstance in a small patient cohort? I think it's probably the latter, but it does sort of probably make it difficult for us to fully appreciate the efficacy of this combination. And probably what we're going to need is more data to understand the safety and benefit of this combination moving forward. One novel treatment that has become available for mantle cell lymphoma that I think has been an important clinical advance is the availability of CAR T-cell therapy. So we saw data presented of Kite X19 for patients with relapsed refractory mantle cell lymphoma based on the ZUMA-2 trial. So this was a group of patients who had received at least 2 prior lines of therapy. And we saw the updated data looking at 3-year follow-up of outcomes of this cohort. Again, the overall response rate in this multiply treated patient population was very high here and in the range of over 90%. But with 3-year data now, what we're seeing also is, very intriguing demonstration that the patients, as with all CAR T-cell trials, the ones that seem to have the most durable benefit are those patients who achieve a complete response. And there's no difference here. You can see the highest curve of those patients achieving complete remission. But we've got data out now with a 3-year follow-up and beyond, where there are patients now sustaining benefit without progression, even at the 4-year mark. So I think we're all eager to see even longer term data, but in a group of patients where I would say that we've had very little to offer sustained benefit, it's clear that CAR T-cell therapy can offer more than what I would expect with the standard agents we have available. So I mentioned that BTK inhibitors have become a seminal therapy for mantle cell lymphoma. We've got several BTK agents approved in this setting. The most recent one approved has been zanubrutinib, which is now becoming a very popular BTK inhibitor for use across a variety of B-cell malignancies, including CLL, based on its favorable safety profile and efficacy. What we saw published was the longer-term follow-up of the relapsed refractory cohort of mantle cell lymphoma receiving zanubrutinib monotherapy. And again, reassurance that this is a very effective BTK inhibitor with overall response rates that were notably high, including a best response where most patients were achieving a complete response with this agent, but now with longer term follow-up, with the median follow-up being 3 years, we can see that the 3-month progression-free survival is roughly at that 50% mark. So again, with BTK monotherapy, 3 years of follow-up, we're seeing that about half of the patients are still sitting in remission at that time.
So that was really great. That's really interesting about the triangle study. We'll definitely talk about that. Incidentally, do you think that's going to change practice?
I think it will most certainly change practice. Having had some discussions post-ASH with many of my colleagues, I'm surprised at how many people are telling me they're not yet ready to let go of stem cell transplant despite that data. I think it was selected as the #1 abstract because it was anticipated by the selection committee that this would definitely change practice. It's the death of stem cell transplant up front for mantle cell lymphoma, but I think it's surprising. I think most people still want to see more details of this trial presented because, as I said, it was a complicated design, and it was almost like just glazing the surface of the information that I think most people wanted to see. But I'm kind of surprised in the discussions that some people are reluctant at this point to really let go. So I'm not so sure in the short term how much will change, but I think it is telling us that that transplant may not be necessary upfront for all patients, and that using these novel agents like BTK inhibitors, maybe we can get to the same place without the same level of toxicity. So I think in my own practice, as I said, I am compelled enough to say that if I had a patient who I didn't think or was borderline for transplant, it would definitely make me more convinced that, to let the transplant go. But here in my own institution, we haven't yet been willing to say for all comers, let's shift over. I think we're just going to wait to see more data come out from this trial.
I guess this is kind of a basic question, but how strong is the data on transplant, prior to this time?
Mm-hmm. There's never been a large randomized controlled trial assessing the utility of transplant. So we've got a lot of suggestive data, cross-trial comparisons, retrospective era-on-era comparisons to suggest that transplant did improve progression-free survival for these patients, maybe even overall survival. But again, no large randomized trials, all sort of compilation of the best data that we have. And what we certainly don't have, and this is really the first trial that's investigated the utility of transplant in the era of novel therapies. So I think the difference is here, now that we've got very effective agents like the BTK inhibitors, do you really need to hammer people with chemotherapy when you have these novel agents? I think that's a really relevant question for a variety of reasons, not only to try and eliminate toxicity from the frontline setting, but when you look at what we have in development in the relapsed refractory setting, we're really seeing the same thing we're seeing in other lymphomas, a movement toward immunotherapy. So what we didn't talk about today was there was a trial looking at glofitamab presented at ASH. So bispecific antibody glofitamab in relapsed refractory mantle cell lymphoma. And that is showing very high response rates and very strong activity, similar to what we have seen in large B-cell lymphoma, and maybe even better activity. So I think, with the availability of CAR T-cell therapy down the road, with the availability likely of bispecifics coming from mantle cell lymphoma down the road, is it really a good idea to be hitting the patients with very strong, high-dose intensive chemotherapy in the form of a stem cell transplant up front when we're going to want their immune system to be strong down the road to have the best efficacy out of these next line immunotherapies? So I think the discussion around transplant will really pick up speed when we start saying, are we doing patients any favors by sort of knocking down their immune system with high-dose chemotherapy when we're really going to need to go on, because transplant is not curative for mantle cell lymphoma, and these patients will need to go on and get second-line and third-line therapy. And if those therapies are going to be based on immune-related therapies, maybe we don't want to hit them so hard with transplant up front. If there's good data to suggest that we can do just as well with novel therapies, that isn't going to have the same, hopefully, prolonged immunosuppressive effect.